So with that, I would like to ask Dr. Alexander and the rest of the team to come up here as we transition into our cancer panel. I think it was 2018 that we had a panel on cancer and kind of gave an update of what was happening at that point in time. And that was well received. We had lots of questions from the floor. And since that time, despite COVID, our team has continued to really take a close look at all the situations where someone was diagnosed with cancer and to really dive into that more deeply to see what might be unique. And so just looking at the data, and that's some of the things that they will present today, they have actually made recommendations for changes to screening, and they'll share all of that with you. And then we'll also touch a little bit on probably what we're working on as we're looking at opening up oncology services at the TCC expansion, which we're never going to be able to do everything, but certain types of cancer, certain types of medication, we will be able to treat some of our patients closer to home. And so I'm going to turn it over to Dr. Alexander, who will moderate, and I'll just be off to the side. And then once we get to Q&A, I'm happy to be up here with you.
See, Jacqueline, and thank you everybody for the comments. I've taken notes on things we can be working on. So Vangwinzi Shalaknai, Shojri Elisa Alexander Oji, Bantakwichin Ichli, Shahan Vojri, Emily Kelly Oji, Sat Shati Vojri, Graham Kelly Oji, Shitsu Vojri, Mary Lazarus Oji, Sat Shitsi Vojri, Lazarus Charlie Oji, Techik Watsan Ichli, Shakai Vojri, Edward Alexander Oji, Diginaigo Vojri, Kaihinjik Chilil Shravya, Batseve Satpia Oji. Good afternoon, everyone. My name is Elisa Alexander. I'm a member of the Buntakwichin First Nation from Old Crow, and my family is from Old Crow and New Zealand. My wonderful husband is Edward Alexander, and we have 5 children together. Some of you have probably seen the little baby around interrupting your meetings. I'm trained as a family doctor, and for the past 2 years, I've been serving as the senior medical officer for TCC. Prior to this role, I worked in the urgent care as the lead physician, and prior to that, I spent 5 years working in Guchaje as a family doctor. I'm honored to be working for you guys in this role and working with your amazing health staff. Some of these amazing health staff are here today on this panel, and I wanted to ask them to introduce themselves to you, and then we'll get into our presentation. So, Mike.
Hi, everyone. My name is Mike Rylance. I'm a physician assistant. I have been at the Chief Andrew Isaac Health Center since 2008. And can you hear me now?
Yes.
Oh, hi. All right, so I'll start that again. My name is Mike Rylance. I'm a physician assistant. I've been at the Chief Andrew Isaac Health Center since 2008. I spent 8 years working in family medicine, and then for the last 5 years, I've worked in general surgery with Dr. Sigonis. I've been on the Cancer Case Review Committee, which is one of our cancer committee teams, since 2015, and I am currently the chairperson of that team.
Thanks, Mike. Hannah Bryce Smith.
Hi there. I'm Hannah Bryce Smith, and I am the RN case manager for cancer care at TCC, and you're going to get to hear a lot more soon.
Jenny Dewar.
Hi, everyone. My name is Jenny Dewar. I'm from Delta Junction, Alaska, and I went to school at UAF. I'm your cancer prevention coordinator.
And Dr. Garish.
Yeah, hi, I'm Steve Garish. I'm one of the physicians chief. I came to Alaska in '78 and started working in Bethel, the YK area. I worked there many years, and then I worked a lot of years in Bristol Bay, Dillingham. I worked in the North Slope. I worked at A&MC, and then I've worked here at the TCC several times, and I've been here about 7 or 8 years this last time. I also spent about 3 years working with the Maori population in New Zealand, And then I spent about 5 years in Africa working on healthcare there. So, but most of my healthcare has been with tribal health in Alaska, starting in Bethel.
Let's see. So as Jacqueline mentioned, we had a panel presentation on cancer about 5 years ago. And so we were invited back to present to you guys updates on our current processes, data, information, and what we're doing to improve our care around cancer care. So I wanted to thank everybody for inviting us to be here today. You may notice that we tried to coordinate our outfits. We're all wearing blue in honor of March, which is Colon Cancer Awareness Month. So for the first presentation, I'm really honored to be able to share a story from one of our patients. Mr. Sam Dimentif approached our cancer care RN case manager, Hannah, and he offered to share his story with us. So his son, Adam, produced this really beautiful video, and I'd like to show that to you now. So I'll get the IT team to put it on.
There is deep and thoughtful leadership for us. I want to talk to you about my cancer story. My name is Sam Dimentif. My nickname was Birdie. I was born down in Holy Cross on the Lower Yukon River in 1939. Working on the boat all early part of my life, working on our river boats up and down the Yukon and Tanana rivers, up the Kayakuk, up the Fianoko and the Iditarod, and not realizing that we're actually living out on the land, out on the rivers. And it was beautiful. It was wonderful. I go through my life, military, married, having our kids, and we moved to Fairbanks and lived there most of the rest of my life, including up to now. Well, you know, when I think back to my health, a year ago, I felt like an indigestion. And so I got up and walked down the hallway and walked back, and all I remember was falling back and fainting. I was coming to in Fairbanks Memorial Hospital and was told that, yeah, I had a heart attack. And my heart doctor explains, you do need to go through heart rehab. That means you have to start exercising. So 3 months of rehab, Sam. After I got done with that, I had this pain in my hip area, and it got worse. I went down to first care, and the guy says, you may be having an appendix problem. So I'm gonna set up so you go through an MRI. Doctor that was taking care of us then called us in. He said, you have cancer. At that moment, I felt this stunning news. I can't believe it. And I know, I looked at Mary, and she was just bent over, and she was just, we were both really affected by this cancer. I know what it feels like when you have someone in your family getting close to dying or sick, seriously. It really affects your whole demeanor.
We went through a lot of fear, a lot of anxiety. And I have to say that as his wife, I wanted to do everything that I could because we knew that it was going to be tough. And there were times when I felt very lost and vulnerable, and I was afraid that I wouldn't be able to do what I needed to do without falling apart myself.
Then is when we started being introduced to our TCC cancer advocate. At that moment, from that moment on, we knew we had someone with us. That was Hannah, our navigator, helping us through this whole thing. She gave us strength. She gave us confidence. She says, so I want you to know that I'm here for you, Sam, and you, Mary, you both. So she stepped right in. She says, I know the nurses, I know the surgeon, I know everyone involved that you're working with, and I will contact them, I will tell them, I will ask them, I will get things straightened out for you. So she had to work with the first doctor, and then she had to work with a heart specialist, and then she had to work with a surgeon, then she had to work with the oncologist in Anchorage. Hannah guided us through all of that, including setting up a second surgeon operation, which took out a portion of my colon, and she was able to coordinate that so it could be done here in Fairbanks.
On one particular occasion, we had a doctor's appointment set up on Zoom, and we understood that one of our grandkids was going to be playing in a band, and we wanted to go there. She got right on it and got a hold of this doctor and was able to change the meeting for the next day, and we got to go. And boy, did it make us happy to see our grandson up there playing Christmas music. We left there just feeling so good that we didn't miss that, and that somebody cared enough to put that first. It just really gave our spirits a boost. And boy, we needed it, didn't we, Sam?
Sure did. If you had a cancer diagnosis or have concerns about a medical test or fear about any procedure, I encourage you, along with my wife, to trust that you can get help you need, and you will be supported and guided as you go along. It is a good feeling. It provides confidence and hope. Confidence and hope. I went through chemotherapy for about 3 weeks, and that was tough. But the oncologist told us your cancer scan showed no evidence of disease. You know, that's a great feeling. Brings tears to my eyes now. And I want to tell you that I'm glad this program is in place. And thank you for this. TCC, on behalf of my wife and I, thank you very much.
So while Tyler's pulling up our PowerPoint, I just wanted to thank Mr. Dimentif again for sharing his story and coming forward and offering to do the video, and for Adam producing such a beautiful video. We really appreciate it. And to his wife, Mary, as well, for sharing her story with her husband's journey. So the second portion of our presentations will include an overview of our cancer case review and our cancer care committee and the role that they play and what they do. Hannah Bryce Smith will discuss her role as the cancer care RN case management manager, and Jenny Dewar is going to do a presentation on adenoma detection rates and colonoscopy screening intervals. And Dr. Garish is going to give an overview of lung cancer screening, and then we'll have some time for question and answer. So I will pass it over to Mike Rylance.
All right, can everyone hear me? Hi, can everyone hear me? All right. So once again, I'm Mike Rylance. I'm the chairperson of the Cancer Case Review Committee, and I'll tell you a little bit about what we do. I can say that in all my years in Native Health, 13 now, cancer has really been a perennial concern amongst the patients that I've seen. I've had people express to me concern that cancers are diagnosed in a timely fashion and that people receive treatment as soon as possible. I've heard worries about Native people getting I've heard worries about Native people get certain cancers more often than the population at large. I've also heard a lot of concern that our patients need to have access to the best possible treatment for their cancers. Because of all these worries, in 2015, we kind of came together and formed a cancer team to look more deeply into the issue of cancer in our population. This is a picture of the current members, or some of the current members of our cancer team. There's representatives from the Cancer Case Review Committee and from the Cancer Care Committee. Dr. Alexander participates in both of those committees. So the Cancer Case Review Committee, we initially formed this committee in 2015, and at first we were trying to answer the question of whether or not we were diagnosing cancers soon enough. And it turned out that that was kind of a hard question to answer, partially because we didn't really have data on how soon we were diagnosing cancers. And the other thing that was complicated about it is there's really no national standard of care for how quickly cancer should be diagnosed. What we set as a goal was that patients would receive a cancer diagnosis within 30 days of presenting to care. So if someone showed up, was having symptoms that were suspicious of cancer, we would work, or our goal was for our system to get them through the diagnostic process and get them a definitive diagnosis within 30 days. And so once we established that goal, we went and we looked back at all the patients that had been diagnosed with cancer that year. And what we found was that although most of the time patients were definitely getting diagnosed within that time frame, there were some folks that took a whole lot longer to diagnose. And so that group of patients, we looked more closely at their cases, and we found that there were some common problems that were affecting their care. With that retrospective look back, we made a lot of changes that year, and we instituted a lot of safeguards for our patients that are still in place to this day. Since 2015, we have continued to meet on a monthly basis, and we review every single patient who is diagnosed with cancer. We take a look back at their medical care over the years that preceded that diagnosis. Currently, our committee has two sort of main goals. The first goal is to ensure that all patients get a quality review after their diagnosis to make sure that we're doing as good a job as we can. Some of the things that we look at in that quality review are the timeliness of the patient's diagnosis and their initial intervention, as well as the stage at which the patient was diagnosed. Cancers that are diagnosed at a stage 1 or a stage 2, which are considered early diagnoses, are much more treatable, and on occasion they can be a curable cancer. Cancers that are diagnosed at a more advanced stage, a 3 or a 4, can have fewer treatment options. They're often still quite treatable, but seldom are they curable. Obviously, the goal of all of our health services is to make sure that patients get diagnosed early so they have the best possible chance of a cure. We also check to make sure that patients who were qualified for screening, met guidelines for screening, received appropriate screenings. Common examples of cancer screenings include mammograms, pap smears, and colonoscopy. We also look to make sure there were no issues with coordination of care between Tanana Chiefs Conference, ANMC, and local cancer doctors. If we do have concerns about the care that one patient received or care that was delivered by an individual provider, those concerns are escalated frequently to either Dr. Alexander's level or the medical practice committee to further review that case. If we notice something that really is a systematic problem or an opportunity for system change that can make things better for all of our patients, we discuss that in the next committee that I'll review, which is the Cancer Care Committee. The second goal of all these case reviews is really to collect data on cancer and the way it affects the Alaska Native population. We know that certain cancers occur more frequently, that they occur at younger ages, and we take all those things into account. We certainly consider the age of the patient at diagnosis. Colon cancer, for example, is one cancer that we see that occurs more often in Native people and at a younger age. Because of this, we've changed the way that we screen for colon cancer, and we continue to adapt the way that we screen for colon cancer based on the data. Jenny Dewar will talk more about this later on, but we no longer recommend that we wait until 45 or 50 for a colonoscopy. We say you should get your first scope at 40 years of age. Even if you don't have polyps now, we recommend not waiting more than 5 years between colonoscopies. We also consider patients' family history, and by doing thorough case reviews, we've been able to identify patients and families who would benefit from genetic testing. Another thing that we look at is patient smoking status. As Dr. Garish will talk about later on, the current smoking rate in our population is 36%. This is double the rate of smoking in the population at large. Fully 75% of the patients who are diagnosed with cancer in our reviews have a significant history of smoking. They're either current smokers or they smoked for many years. 96% of the patients who have been diagnosed with lung cancer have either been heavy smokers for much of their life or had many years of secondhand smoke exposure. So this is a slide that shows the relative frequency of the different cancers in our population. As you can see, breast cancer is far and away the most common cancer that we see diagnosed in our patients. This is in keeping with the population at large. So we know that Alaska Native people get breast cancer at about the same rate as all comers. The good news with breast cancer is that frequently it's diagnosed at an early stage when it's highly treatable. Many patients are able to be treated with surgery and radiation therapy and sometimes a hormone blocking pill. A lot of the time people don't need chemotherapy, and often those patients can be cured. So that's good news. The second most common cancer is colorectal cancer. And like I said earlier, this occurs a lot more frequently in Native folks. We screen for it pretty aggressively in our system, and our goal is to catch it early when it is treatable and curable. The other benefit of colonoscopy is that it can remove precancerous polyps, and therefore it's also a preventable disease. And I think that's something that we should really stress. We can prevent people from getting colon cancer with routine colonoscopy. The third most common cancer, and this is not such a good news, thing is lung cancer. We know that it occurs more frequently in Native folks, and that increased frequency probably tracks with the increased rate of smoking and tobacco use amongst Native people. Lung cancers are often at an advanced stage when they're diagnosed. And so they have fewer treatment options and they have a lot higher mortality rate. Because of this and acknowledging the impact that lung cancer has on our population, we're actually planning to institute a lung cancer screening program when we open the new building and have an expanded radiology department. And Dr. Garish will talk more about that later on. So the goal of the Cancer Case Review Committee overall is really to make sure that we're identifying any opportunities to improve the way that we take care of cancer, be that through prevention, early diagnosis, screening, and appropriate and timely treatment. The Cancer Case Review Committee makes an annual report for the medical staff where we review pitfalls and problems that we've seen, and we report every other month to the Cancer Care Committee. So the Cancer Care Committee is the second working group that we have at TCC that's aimed at improving cancer care. This is a multidisciplinary group led by Dr. Garish. Consists of physicians, mid-level providers, nurse case managers, Jenny Dewar, and Dr. Alexander. And we meet every other month and basically just kind of go through all the data that's gained from the cancer case reviews. And we're looking for opportunities to change our system as a whole so that we can deliver better care. Over the years, the Cancer Care Committee has established system-wide screening guidelines for lung, colon, and breast cancer. They have advocated for an aggressive smoking cessation and prevention campaign, as well as an HPV vaccination campaign. They've also established system-wide hepatitis C system-wide hepatitis C screening program with the aim of preventing liver cancer. Remember that hepatitis C is a treatable disease now, and hepatitis C that is untreated is one of the leading causes of liver cancer. So what have we accomplished since 2015? I think first and foremost, we have a good improvement in our understanding of cancer and how it affects the Native population. This has really let us zero in on the cancers that have the greatest impact on our patients. And because of that, we have set in place some very aggressive screening guidelines for several cancers. And our goal, again, is to diagnose these at an early stage when they can be curable. We've also standardized the way we refer patients, and that's kind of a standardized process by type of cancer. And what that does is make sure that patients get sent to the right specialist. And when they get there to see that specialist, that person has all the information they need to provide care to our patients. We've also changed the way we manage referrals to ANMC and elsewhere, and we've created a closed loop process so that patients don't get lost to care after they're referred out. We've enacted prevention measures, including smoking prevention and cessation campaign and HPV vaccination campaign. I would stress that most cervical and anal cancers, as well as many oral cancers, are completely preventable with HPV vaccination. We've established a palliative care program, and the goal of that is to improve the quality of life of patients with cancer and other severe illnesses. Finally, we have hired a new cancer care nurse case manager. She has years of experience working with local cancer patients. She is really great at networking between TCC and ANMC and the local cancer doctors. And she's proven to be a really invaluable resource for our patient. So she's up next and she'll tell you about her role. So I'll introduce you to Hannah Bryce Smith.
Thank you, Mike. So I'm Hannah Bryce Smith, and Dr. Alexander is going to manage my slides because I'm not tech. So I'm Hannah Bryce Smith. I was born and raised Bryce here in Fairbanks. People always ask me, which Bryce? So I'm just going to say it. Anybody a Star Trek fan? I'm third of 5 of Alan Carroll. Got it? Okay. What I wanted to say that was significant about being raised in Fairbanks is we were part of St. Matthew's Church, and my mother served on the altar guild with Hannah Solomon. And my mother was absolutely convinced after she'd had 2 children that she was not pregnant with me. Hannah Solomon gifted me her name when she was right. My mother was 5 months pregnant when I was born. Hannah. I like to think that Hannah Solomon is watching over my career as a nurse and that she smiles to see that I've come back home to TCC. I just want to highlight briefly my career to kind of help you understand who I am and what I've done. This is my 35th year nursing, and in case you have to compute that for a moment, I went to nursing school before computers. I've been doing cancer care in a multifaceted manner for about 25 years of my nursing career. I started out in pediatric oncology, where we mixed our chemo in the nurses' lounge in the back without a hood, out in Seattle, Washington. I then came back to Alaska and worked as the Tok nurse, which was an adventure. I went from Tok to Anchorage and then the Mat-Su Valley, FMH, and now I think I finally come home for the end of my career to TCC. I see myself as a starter and a grower. I'm a believer in mustard seeds. I think that planting seeds and watching them grow is how we make change in the world. When I look at cancer, I was the one who helped bring home infusion therapy to the Valley. We had so many patients in Wasilla that were getting treatment in Anchorage. And so they were having to drive to Anchorage, get their treatment, and then drive home. We opened an infusion therapy center. And then we started saying, hey, we need to put in some central lines a little better than the way we're doing them. And a group of 26 nurses, me included, approached the State Board of Nursing, and now nurses can put PICC lines in across the state of Alaska. When I first came to FMH, we were doing infusions in rooms that we were also doing wound care in. And I had a minor temper tantrum. I'm known as the Tiny Terror. And pretty soon we had an infusion room with 4 chairs. Now, if you've been to the FMH infusion room, it's its own department. The late Dr. Carroll took me under his wing. There were some cancer clinical trials patients that he wanted me to work with. And I started working across the Northwest to bring more cancer trials to rural environments like in Fairbanks. That led to being one of the charter members of the statewide cancer care partnership that is still alive and going in Alaska today. And we look at prevention, survivorship, and treatment across the state. I was the first certified breast health nurse in imaging and cancer, a great big word. And all that means is I know what it looks like on an image, on a radiograph, on an x-ray, and I can deal with cancer. I was part of the Circle of Hope and the breast cancer navigation program at FMH. And then I retired and I stayed home to take care of my parents 5 years ago. A year ago, in a week, my 1-year anniversary, I saw the job for the cancer care case manager for TCC, and I decided I was done being retired, and I came back to work, and I haven't looked back since. One of the main roles that I have is to collaborate across communities, across villages, statewide, and out of state, because so many of our referrals end up at ANMC or out of state. All the care that we do for cancer is based on a national database of guidelines for care. It guides us through an algorithm process that helps determine workup and treatment planning. Our patients from TCC get presented at ANMC and FMH in a process that is referred to as tumor board. Patients ask me all the time, I want a second opinion. Just get presented at tumor board. You get 55, 72, 91. Every time they meet for tumor board at ANMC, there is a minimum of 40 people present. And I'm talking about a team of doctors, a team of oncologists, a team of radiation therapists, a team of radiologists, a team of pathologists, nurses, social workers. Every one of them is looking at your de-identified information. So your name's not up there, you're just a number, but we are looking at your tumor, and we're taking those national guidelines and personalizing your treatment plan, then communicating that back to TCC so that your PCP and your team in Fairbanks can support you through this decision. So how do we determine what goals for care are? When we say, what are your goals for care? We mean looking at the holistic whole patient, the whole you, your family, your village, your community. We want to make that plan of treatment individualized. And when I say plan of treatment, there are a lot of cancers that have definitive active treatment. We're looking for a cure. There are a lot of cancers where we're looking at palliation, palliative care, where we're looking at managing symptoms and extending quality of life. And we also have cancers where we're looking at end of life and hospice care. What is important to me is to be an advocate, help navigate this plan of treatment with you, and hold all the pieces together so that you feel informed and you feel part of the shared decision-making that's happening. My job is to take all the puzzle pieces in your cancer journey and make that finished puzzle reflect what you wanted to see at the end of treatment. Hopefully you traveled the twists and turns with the support of your team here at TCC, because we were behind you all the way. Thank you very much.
Thanks, Hannah. So up next is Jenny Dewar.
Afternoon, everyone. My name is Jenny Dewar, and I have worked for TCC for almost 10 years now, and 8 years I've been in cancer prevention. And I'm here to share some data that we've collected over the years and how that's impacting our colon cancer screening guidelines. So these are some common abbreviations you're going to see as I go through this PowerPoint. I'm going to talk about the big ones real quick. So CRC is the abbreviation for colorectal cancer. Early stage, that's looking at colon cancers that are stage 0 to 2. And those are considered early cancers that we can treat and potentially cure. And late stage are cancers stage 3 and 4, and those are harder to treat and harder to cure. ADR, the last term on there, stands for adenoma detection rate. And I'm going to be discussing that in depth. That is a quality benchmark for providers who perform a colonoscopy. The picture on the left is what the doctor would see when they're doing your colonoscopy procedure. And there is a very obvious polyp there that the doctor is about to remove and send to pathology to be tested to see, is this polyp normal benign tissue, or is this precancerous and something that could be dangerous if left in your body? The picture on the right shows how a very small polyp, if left in the body, can go from stage 0, 1, 2, 3, 4. So we want to get those polyps out when they're small and before they're causing you any problems. To kind of give you a summary of what we're going to be going over, I want you to take away that we are looking at every single colonoscopy procedure report. So every patient who has a colonoscopy, we go through and we collect data points to make sure that patient had a good scope and that we can improve care with this information. We're starting to find some trends, and those will get strengthened as we continue to collect more data over the years. And we've decided that 10 years between colonoscopy follow-ups is a very long time for a potential adenoma to get to grow and potentially become cancer. So in response to this data that I'm going to share with you today, you're going to see why our providers decided to no longer give 10-year repeat intervals, and that we plan to correct every patient who was given a 10-year repeat interval and reduce it to 5. And right now that's over 600 patients that we need to correct. So colon cancer, why is this always coming up? Well, the reason is for Alaska Native people, they're more likely to die from colon cancer, 2.3 times more likely compared to the non-Native population. The Alaska Native Tribal Health Consortium found that 1 in 12 Alaska Natives are going to be diagnosed with colon cancer in their lifetime, and we want to change that number. Current literature finds that adenoma removal, being that polyp that got resected by the doctor, is the greatest benefit of colonoscopy because that's preventing it from having a chance to turn into cancer. And the adenoma detection rate in our patient population is the highest that's ever been reported. And we are working to get a paper published on this. So this slide is talking about the adenoma detection rate. So I'm going to spend a little time explaining what that is and why this is important for you to know. So the adenoma detection rate is a quality benchmark for doctors who perform a colonoscopy, and it considers patients who are age 50 or older who are undergoing their first ever screening colonoscopy, so they have no symptoms and they did not have a family history of colon cancer in their immediate family members. And by the lower 48 standard, they have a goal of 25% of all the patients who undergo their first ever colonoscopy should have an adenoma removed. So that is represented by the blue box on the right. That would be our patients who are age 50 or older. And that 25% goal line is the red hash marks running across. So when we averaged all our patients together, you can see we are definitely exceeding that by a lot. 68% of our adults are coming back with adenomas, at least one removed during their procedure, if not more. So I wondered, well, what about our younger patients who the lower 48 wouldn't consider for this screening? And so looking at patients age 40 to 49, because we start screening at age 40, we had 35% of them come back with an adenoma removed on their first ever colonoscopy. And again, that's far above the lower 48 standards of 1 in 4 patients for age 50. As a result of that, I do want to mention our providers decided to set a goal of 50% for adenoma detection rate, regardless of the patient's age. So if they were age 40 versus age 60, we're looking at 50% as our goal. This slide here is looking at patients who have already had a colonoscopy. They had an adenoma removed, and they were asked to return for follow-up to see if those polyps came back or if they developed new adenomas. So the yellow represents patients with a history of adenomas who came in for follow-up. 65% of them had more adenomas removed. That's pretty concerning. And there's the smallest little green sliver you might not be able to see at the top of this pie chart. 2 of those patients, 2 out of 520 of them, had colon cancer on their follow-up exam. So in summary, what this means is that when patients have a history of adenomas and we bring them back, it's very, very common that we find more adenomas, and we're doing a great job of preventing those adenomas from turning into cancer. So we want you to have these follow-up procedures. This is an age distribution of our patients who are diagnosed with colon cancer. I'd like to point out the darker blue boxes to the left. These are patients who are under the recommended screening age of 40, who unfortunately were diagnosed with colon cancer. The bulk of our patients with colon cancer were diagnosed between the ages of 50 to 69, with the median age being 59, which is 4 years younger than what the state reports. Now, I'd like to also point out, of these patients, how many of them were diagnosed with late-stage colon cancer? Unfortunately, with the younger patients, it's 100% of them under the age of 40. For our older patients, it's right about 50% of the time. I'd like to talk about interval colon cancer now. This is another way we can look at how well we're doing as a facility. So the World Endoscopy Organization defines an interval colon cancer as when a patient has already undergone one colonoscopy and they are told, you did not have cancer, please come back in 10 years, 5 years, 3 years, whatever that may be. And before that patient is due for a follow-up, they end up being diagnosed with colon cancer. I'm going to give you some examples. So Annie had a colonoscopy in January of 2015 and was told to repeat in 5 years. So she would be due for follow-up January of 2020. Annie was a great patient and she came back on time and she was diagnosed with colon cancer. She doesn't count as an interval because she was on time and up to date. Now our second patient, his name is John. He was given the same information as Annie. John came back a year before his recommended repeat date, though, and was diagnosed with colon cancer. Sorry, a little IT issue here. John would count as an interval colon cancer because he was up to date and not yet due for colonoscopy. I want you to think of John as being the color blue on this next slide, and Annie as being the color yellow. This is a pie chart that reflects 55 of our colon cancer patients, and it's broken down by their screening status. Dark green is patients who were under the recommended screening age of 40. So these are our very young patients. Yellow is patients like Annie, who was up to date and came in for screening on time as recommended. Blue was like John, the interval colon cancer. So he was up to date and not yet due for repeat screening. And the light green represents the bulk of our patients who are overdue. When you add up the underage, the up to date, and the interval colon cancers, we're over 30% of our total colon cancer patients meet those criteria. And when it comes to patients who were overdue for colonoscopy, over 56% of them were diagnosed on their first ever colonoscopy. So these are typically patients who might have been offered or encouraged a colonoscopy and declined and put it off and put it off. And maybe they ended up not feeling good and letting their doctor know and finally agreed to colonoscopy. Now this looks very complicated, but it's the same information as the last slide, but I added in the patient's age at the time they were diagnosed with colon cancer. And I'm going to walk you through so you can understand what these dots mean. I'd like to start with the vertical axis that represents the patient's age at time of diagnosis. So the higher up the dot, the older the patient was at their time of diagnosis. And looking at the horizontal axis from right to left, on the left side, these are patients who weren't yet due for screening colonoscopy. And to the right side, these are patients who were overdue. I want to talk about the patients who were overdue first. This is the bulk of our patients who are diagnosed with colon cancer. So in this red box, these are patients who had their first ever colonoscopy and were given the unfortunate news of being diagnosed with colon cancer on that exam. This is 56% of our total patients who have colon cancer, and a great opportunity to try and get these patients into care sooner. To give you an example, if you were 50 years old and you finally agreed to colonoscopy, you were 10 years past the screening age of 40. So that's how we ended up with a dot right there. We had several patients who met that criteria. This green box represents patients who were under the age of 40 and therefore not targeted for screening. If you were 30 years old and diagnosed with colon cancer, that's 10 years before the recommended screening date. So that's how patients ended up in this box here. Now, if you can remember John was the interval colon cancer who he was up to date and not yet due for recommended repeat screening. The interval colon cancers are in this blue box. And I looked at it, how many of these patients were on a 10-year repeat interval? 3 of them were, and all 3 were advanced cancers. So these patients would have benefited if we had had this data sooner and reduced our screening intervals from 10 years to 5 years. We could have made a big difference here. And so even though we didn't catch these 3 patients, I'm looking forward to not seeing anyone else circled like this. Just to the right of the blue box, the patients who fall directly on the vertical axis, those are the patients like Annie, who was up to date, who came in on time and was diagnosed during that exam. The patients slightly further off to the right of the blue box, they have had a colonoscopy before, but they were overdue slightly for follow-up, most of them less than 3 years beyond their recommended repeat date. So I realize this information can be really hard, and I want to stress that I put these information packets together, and I'm not in any way wanting to reduce our patients to just being a dot. I know every single one of those dots is someone who's loved, who's a family member and has friends, and I want to see these numbers change. And so something you can do to help us as an organization is think about your lifestyle factors, how you can reduce your personal risk of colon cancer, because there are some things that you can do. Having a healthy diet, exercising every day, not smoking, as Dr. Garish will speak about here soon. Finding out your family history. Do you have anyone who was diagnosed with adenomas in your family or colon cancer? And then specifically finding out how old were they when they were diagnosed, and letting your doctor know, because that may change when you should have a screening exam. And it's very important to stay up to date on your recommended cancer screenings and not to postpone follow-ups. And if you have symptoms, even if you're up to date on your colonoscopy, please, please, please tell your doctor. The takeaways I'd like you to have from this presentation is that through colonoscopy, we can remove adenomas and prevent colon cancer. And postponing colonoscopy or outright refusing is the main reason our patients are developing this disease. And we are now going to go to a 5-year screening colonoscopy interval. Patients who are given a 10-year interval will be corrected. And if that happens to be you or someone you love, you can help speed the process up by calling us, and we're going to be happy to get you in. And we're going to continue to use data to make decisions that benefit everybody and prevents cancer for our patients, our friends, and our family. Thank you very much.
Thanks, Jenny. So how's everybody doing? Are you ready for one more presentation with a bunch of data on it? Looking good. Okay. So Dr. Garish is up. He's going to talk to us about lung cancer screening. Do you want me to flip the slide screen?
Just the green button.
Yeah.
Thank you, everybody, and thank you, Jenny. That was very interesting. Okay, let's go here. I'm going to be talking about smoking and lung cancer, and a program that TCC is going to be rolling out this year to do lung cancer screening with low-dose CT. First, a little background. I think it's important that everybody recognize that lung cancer is the #1 cancer killer in the nation by far. It's more than the colon, breast, and prostate all put together. And it's a bad cancer, as Mike Rylance has already indicated. Lung cancer, unfortunately, often presents late. Only about 20% of the folks that get lung cancer are alive 5 years later. It's a bad cancer. These numbers apply in Alaska as well, and they apply in the Alaska Native population, where it is also by far the #1 cause of cancer death. Between 2014 and 2018, there were over 200 deaths of Alaska Natives in Alaska due to lung cancer. At TCC, we've had 53 cases that we have reviewed since we started reviewing, which Mike Rylance talked about in 2016. Of these 53, 41 were as I implied, advanced when they were found. This means we have about 5 or 6 deaths every year at TCC from lung cancer. Now, we know that almost all lung cancers are caused by smoking. And of our 53 lung cancer cases, 50 were smokers. So that, again, reaffirms that smoking is the cause of lung cancer. On the left is a graph that shows the prevalence or the incidence of smoking in the Alaska Native population. And Mike also referred to that. It's considerably higher, about twice as high as the non-native population. And while both numbers have been slowly going down over the years, they are both still high. And the Alaska Native smoking rate has remained remarkably high, and again, about twice as high as the non-native population. That little graph on the right, I think is important. It has an important point. Smoking causes lung cancer, but it doesn't occur right away. It occurs 30, 40, 50 years after you take up smoking. And you can't quite see it there because I'm blocking it, but this little graph starts in the 70s. And you can see back in the 60s and 70s, the lung cancer rate in the native population was the same as in the non-native population. But then in around 1980, it suddenly jumped up and it's been higher ever since. And if you look back to when tobacco smoking was really introduced into the Alaska Native population, it was around World War II. So it was about 40 years before this. So you can see that about 40 years after smoking became common, suddenly lung cancer picked up and it's stayed high ever since. Okay, can we screen for lung cancer? We do screen for other cancers. We do mammography to screen for early breast cancer, and it works pretty well. Jenny just talked about screening for colon cancer, which works pretty well. But unfortunately for lung cancer, we have not been able, up until recently, to do any kind of screening. For years, we would take chest x-rays, but it didn't work. By the time the cancer shows up on the chest x-ray, it's already advanced and too late. For a while, they would collect sputums, hoping that they could find cancer cells in the sputum and catch it early. That failed as well. But over the last years, what's called the low-dose CT exam has been identified as a way of catching lung cancers early in some cases. So it does work. So what is low-dose CT screening? Most of you probably know what a CT is. Well, the low-dose CT is, as the name says, is a low dose of radiation. It's very quick, just takes minutes. It's focused on your lungs, and it gives a great picture of your lungs. And with the low-dose CT, they're able to pick up tiny little tumors as small as a grain of rice. And identify those for investigation. And as it says at the bottom, it's higher than a chest x-ray, but it's quite a bit lower than a regular CT. So it is considered, the radiation risk is considered quite low, even though you have to get this done every year. So did we start low-dose CT screening at TCC? Yes, we've been actually doing it for years. But in the beginning, it was a lousy test. It had lots and lots of errors, a lot of false positive reports, and was not very effective. But we've been doing it case by case, patient by patient, when it was indicated. But with the new expansion of the new building and our own CT, we're going to be rolling out a program in this year to really make it part of the standard screening program for all the patients who are smokers and meet the criteria. But how well does it work? I think this is important to know because some people may think, well, if I can get screened every year, then I can keep smoking. It doesn't really matter. Unfortunately, it works, but it doesn't work really well. The first study, you probably don't hear much about studies, but this is important because this was the only study that all these decisions around the nation all the decisions were made based on this one study. And it was called the NLST study. And they took about 50,000 people, followed them for 6.5 years. Half of them had low-dose CTs every year. Half just had regular x-rays. And they found that at the end of that time, there was a 20% reduction in death from lung cancer. That's real. It's a real reduction. It's not dramatic because it still means that 4 out of 5 people, when they found it, it was too late. It was already advanced, but it was real. And based on that, in 2013, what's called the U.S. Preventative Service Task Force, which is a big recommending agency, they recommended that we start offering low-dose CT for those that are 55 to 74, have 30 pack years, have smoked a pack a day for 30 years, and are still smoking or quit within the last 15 years. Because remember, even if you quit 10 years before, your risk of lung cancer stays and gradually goes down over time. So they recommended back then that this be offered to people every year up until they're 75. And we have been doing that a bit, and they were being done at FMH. Then in 2020, a new study came out called the Nelson study. It was a big study, again, of tens of thousands of patients. It was done in Europe, and they followed them for 10 years. And they found that there was a 25% reduction in death from lung cancer. Again, that's only 1 in 4, so it's not dramatic, but it's something. It's better than we ever had before. But the big benefit, the big advantage of the Nelson study is whereas in the first study, there were lots of false tests. A lot of people would get things back saying, we found something, we got to investigate it, maybe biopsy, go see a specialist, and it turned out to be nothing. It was about 25% of the people had that happen. With this new one, it was only a couple percent. They used new technology and new methods, and it was much better. So this made low-dose CT screening much more attractive because you didn't have hundreds and hundreds of people getting investigated for no reason. And so based on that study, in 2020, the new recommendation by the U.S. Preventative Services was that people 50 to 80, and that's a little younger than the old one, with 20 pack years instead of 30, could be screened if they're still smoking or have quit within the last 15 years. And they extended the age up to 80. These are pretty much the criteria, a little bit different, but pretty much the criteria we will be using when we roll out our program. How many people will be eligible for that? It's really hard to say because we can't look in our computer system and tell how many pack years people have been smoking. But looking at the ages and stuff, we estimate it could easily be 1,000 people that this will need to be offered to, maybe more. So that's the good news. It works. Not real well, but it does really work. So what is the not so good news? It has to be done every year. Some people may think, well, I'll get one and then I'll get another one every now and then, and maybe they'll pick it up. The data clearly shows if it's not done frequently, decades, 10 years, 20, 30 years, has to be done every year, it won't be effective. So anybody that agrees to do this, they have to agree to come in every year for their scan. Abnormal findings are still going to happen. They're not as common as they were, but it would not be unusual to get your scan and to get a report from the radiologist saying, we found something, we need to investigate it. It may be just another scan. It may be a referral to a specialist. That will still happen, so people need to understand that. And based on the numbers from the last study, we will probably have to do between maybe 1,000 scans a year to save one life. So that doesn't sound real impressive, but that's what the numbers support. So we will do a lot of CT scans and probably save, if we do it really well, we'll save 1 or 2 premature deaths from lung cancer each year, if we do it well and we can get everybody screened. Medicaid right now doesn't pay for this, but most third-party insurances will, and TCC has agreed that they will pick up costs. So it's not going to cost any of you extra money. But again, and I want to emphasize this again, because I think it's really important for people to understand that even if we do this really well, about 75, 80% of the folks, 3/4 of the folks, when it's picked up, it may still be too late. And lung cancer is really only the tip of the iceberg of the disease caused by smoking. So now I'm going to get onto smoking, which you've heard, we've brought it up a number of times, but it's probably the single best intervention we could do to improve the health of the population of everything suggested. And I would like to remind folks, we heard talk earlier about drugs and alcohol. Tobacco is an addictive drug, just like those others. It's just that it's not as dramatic. It takes 10 or 20 years, but in the end, the addiction to tobacco causes just as much death and illness as those other addictions. Heart disease and strokes. You don't think of that being caused by smoking, but there's actually more deaths from stroke, heart attacks, heart failure due to smoking than from lung cancer. Lung disease, you've heard of emphysema, bad lungs, COPD, almost as many deaths from that caused by smoking as from lung cancer. Secondhand smoke, they estimate about 40,000 people in the US die every year from other people smoking that they're exposed to. And then as Mike mentioned earlier, there's almost all the cancers we look at seem to be worse in smokers, especially oral, stomach, bladder, liver. Clearly, smoking increases other cancer risk as well. So how can we reduce this illness and death caused by smoking? These two graphs show the benefit of doing the low-dose CT screening. You can see on the left, cardiac disease, and then respiratory disease, secondhand smoke, other cancers I mentioned, that won't change at all with low-dose CT. The lung cancer will be reduced, if we do it well, by 25%. So when you compare those two, doing the low-dose CT will help a few people, but in the big picture, it's not going to have much effect at all on death and illness caused by smoking. So this is looking at a couple other interventions that will make a difference. On the top left is no change. Top right was with the low-dose CT. But if we could reduce smoking by half from what it is, and that would be about what the non-native rate is, it would cut all those deaths by half. So that's a huge, huge reduction. And this is what's remarkable. If people would quit by the time they're 40, most death from smoking is caused by decades of smoking. If people would quit by the time they're 40, almost all smoking-related deaths would go away. So if somehow you could miraculously get everybody to stop by the age of 40 in the population, almost all of smoking-related death would be absolved, would be gone. Even simply, if we could just keep 10 new people from taking up smoking, that would have a bigger benefit than the low-dose CT. So the low-dose CT works, it's good, and we're going to roll it out, and we hope to do it well, and we recommend that any of you that are heavy smokers, or if you have family members or friends that are heavy smokers, you be considered to get this because it does help. But again, if we really want to improve the health of the entire population, we need to reduce smoking. So what does this mean? The last slide here. What does this mean for TCC in this coming year? We are going to be doing it. And we're going to be trying to identify everybody that meets those criteria. And we are going to recommend that they all have what's called a counseling, an educational and counseling and decision-making visit. We are going to be recruiting a nurse to offer this visit where you will be invited to sit down and talk for 30 minutes or an hour so you understand what this means. It's something you will need to do every year for the rest of your adult life. And even doing it is not going to be, it's going to help a little bit, but it's not going to be miraculous. And that we really need, even if you're older, to get you to stop smoking. That will have a greater benefit. So I don't have much else to say on that. I think I've made my point. But if we can reduce smoking, that will have the greatest impact on our health. Thank you.
Thank you, Dr. Garish. So I just wanted to take this opportunity to thank our panel members. They're all extremely humble, hardworking people, and they won't ever talk about how hard they work for you. So I just wanted to take a moment to acknowledge that. Mike sitting on the cancer case review and the cancer care committee with the staff that sit on that with them, they work hours and hours and hours outside of their normal jobs, seeing patients, to delve into these charts deeply and pull the data. And they're extremely committed to improving the care that we provide across our region. Hannah, as you can tell, has extensive experience, and she's embodies Chiwitzin for the care that she provides for our patients. Jenny, I can't tell you enough about Jenny. She's amazing. Jenny says, we looked at this data. We looked at the data. Jenny reviewed, I can't tell you how many Excel spreadsheets and inputted the data. She's just amazing resource. And Dr. Garish, he's our professor emeritus. He is our go-to elder that provides us a ton of guidance. So I just wanted to say thank you to all of them. So we're available for any questions. I don't have an idea about the time.